Thank you so much. Happy to do this again. I was in person with you today. My parents are not in Denver after being stuck here for quite some time during the pandemic, so I miss them because they're with you. But I will. Maybe you can virtually wave at them for me if you see them. I will. I am happy to chat with you guys today. And we'll talk about, the same kinds of information we talked about last time, but I think we've all had a very significant change in our understanding. It is an interesting time in the world in general for those of us who study stress and its impacts, because everyone is sort of pressingly aware of how impactful stressful experiences can be. Everyone has a sense of the way that unpredictability and uncontrollability of the environment impact your mental and physical health in a way that was not true, I think, when we talked in 2019. So in 2019, it was easier for people to do default to an us-them kind of an orientation, right? There's those people who have, stress and trauma, and then other people that don't. Although that wasn't true in 2019, we all sort of live on a continuum of our strengths and risk factors. It's really clear to people at this moment in time that unpredictability and uncontrollability is really hard to manage and has a lot of impacts, and that those impacts are particularly felt for children and families with young children. So the way that the pandemic has undermined caregiving systems and impacted families with young children in particular is something that is really pressingly known, I think, across economic conditions, educational background, that kind of thing. And so while it has amplified the disparities that were present before in ways that are really disturbing and difficult, it is also the case that people have a degree of empathy right now that I don't think is always there. And so it's a really important time to think about what we understand about how stress and trauma impact everyone, and particularly young children and families. That now is a really good time to try to make progress while people are really sort of pressingly aware of what kinds of impacts we're talking about. So I suspect, and it's been my experience in the last year, that I think about the knowledge that I've owned for a long time differently now that we're living through this pandemic, just differently than I did before, right? And that might be your experience too. So if you have different types of questions or just hear things in a different way, that's not surprising, and I'm happy to talk about that more. In the interim, since we talked last, I also I developed another curricula it's related to the others, but it's for early childhood directors and FFN providers. And what's been really interesting, it was really interesting to do that work during the pandemic because that sector has been so strained, and it was really a pressing sort of acute crisis management situation that they were in while we were trying to make some progress in terms of understanding stress and trauma more broadly. So that may be your experience as well. And I'm happy to talk about those things. I just want to check in with the organizers here. So it is 12:12 now. Would you tell me what time you're thinking we'll stop the formal presentation and switch to Q&A, please?
I think whatever makes the most sense for you. If you want to leave 10 minutes at the end.
Okay. And the ending time is 1:30, is that correct?
Time is 1.
Ending time is 1. Okay. So that's like 45 minutes. Okay. All right, great. Thank you. All right. So let's go ahead and talk about, I'm going to try, let's see if I can actually screen share. It's giving me a little grief. 1 second. There we go. Okay, so there we go. Yeah, so we're just really talking about how toxic stress, resilience, and parenting interact, particularly in the context of adversity. But in order to do that, we need to think about sort of some broader perspectives. And I'd like to begin by saying we're going to talk about the scientific approach, but when I was in Hawaii last, I talked much with my colleagues there on just trying to think about this concept, right? So we talked about two-eyed seeing as the basic way of understanding that there's lots of ways to know things, right? There's the scientific body of knowledge, that way of knowing things, and there's and you could think of that as a Western approach to knowledge. And then there is the benefit of seeing things from your own experience, which might include your own lived experience or your cultural experience. So trying to blend a little bit of this idea of thinking about indigenous and Western approaches, but also how you frame, we've probably all had this experience. You go to the doctor or whatever, and you hear something that is medical or scientific knowledge, and it does or doesn't really jive with your own experience. And so just trying to think that we get the best and deepest perspective on a particular issue when we can blend our own personal cultural knowledge with with whatever is known in a bigger context from a scientific or medical perspective. Understanding that scientific and medical knowledge is based on averages, right? It's based on big data sets, lots of people, but that might not be the exact experience of any one individual person. So just want to acknowledge that the best way to see far and deep is to bring your 2 or 3 or 4 or 5 ways of knowing things together to think about that distance. So I just want to acknowledge that, and I want to acknowledge my colleagues in Hawaii for sharing that concept with me, which has actually been really helpful in lots of parts of the US to try to think about how we talk about these issues. Okay, so we do know that there are long-term and significant effects of chronic stress, where chronic stress is stress that is prolonged for a sustained period of time. Serious or significant stress has to do with the severity of the stress, but chronic stress is more about the duration and the unrelentingness of it. We know that chronic stress has impacts on both whether you get sick and what happens after you get sick. And that's definitely true for cardiovascular disease, diabetes, and infectious illness. We know some about how that happens. So the way that stressful experiences impact your long-term health has to do with changing the set points inside your body. And those changes that happen because you've experienced lots of stress are meant to protect you. They're meant to help you in the short run, but they actually have costs in the long run. So for example, a really easy way to think about this is to think about obesity. When you experience lots and lots of stressors over and over, you're telling your body that you're going to need energy, and you're going to need it unpredictably at unknown times when you may or may not have recently eaten. And when you tell your body that you're going to need energy, you're telling your body that it should store energy. We store energy in fat. And that also is a huge risk factor for chronic diseases down the road, right? So if you experience lots of stress, you're more likely to carry additional weight. You're in fact more likely to carry it around the midsection. And that can help in the short run and cost you in the long run. So there's a number of different ways that happens, where we see these changes of risk factors that help you respond in the immediate situation of a threat, but actually years down the road can really take a toll. So that's an important concept and a way to think about how stressful experiences end up being both helping you in the short run and costing you in the long run. We also know that stressful experiences change the way you think about things. They change what you remember, what you attend to, and those changes, again, can be really helpful in the situation where you're trying to detect and respond to threat in a very tight timeline, but they can impact your ability to remember and reason about things that are not acutely related to the stressful situation, especially abstract concepts, so things you might learn in school or that have sort of longer term relevance for you. We also see pretty significant impacts of stress on mental health. So both depression and anxiety, but also externalizing behavior. So that would be things in adults like antisocial personality disorder. And in children, we see that as conduct disorder. In young children, you might just see that as biting and hitting, that kind of thing. You can also see that in terms of withdrawal behavior. And then the thing that is sort of really galvanized this whole body of research is the fact that chronic stressful experiences actually accelerate aging, and that is something that we can measure. So we know how it happens. We can look inside the body to see whether it's happened, and it is actually reversible. But if you stay on the trajectory that you're on, you can have a very significantly reduced total lifespan if you experience significant stressful experiences, particularly in childhood. So we all know that there are certain behaviors that have significant impact on life expectancy, where life expectancy is the age that you're expected to live based on your year of birth. Your year of birth, and sometimes additional factors are used. So the most common is sex, biologic sex. So women live longer than men, for example. Sometimes also race and ethnicity are taken into account. And we've had in fact, with COVID, because of increasing disparities, we've had changes to life expectancy happening because of that, because of disparate impacts of the pandemic on individual life expectancy. So you have this number that's your life expectancy, and then it can be changed by things that happen across your lifespan. So smoking can reduce your expected life length by 10 years, obesity 6 to 7 years, high blood pressure 5 years, diabetes 7 to 8 years, and chronic and severe stress in childhood can reduce your life expectancy by up to 20 years. So this dramatic impact on life expectancy has really galvanized a lot of research and attention on this topic to try to think about how we can prevent this type of stressful experience in childhood, but also what we can do in childhood and later in life to correct that trajectory, or at least lessen that duration, right? Try to turn that around. So there's lots of different ways to think about stress and its effects, its negative effects. So you can think about stressful experiences that are embedded in adversity, adverse conditions, threatening environments, violent environments, that type of thing. There's also a whole literature on poverty and scarcity. So what happens when people are experiencing low income, they don't have enough resources. There's another piece of the puzzle, which is inequity. That's when, although you might not be in acute poverty or scarcity conditions, there's big disparities among people in a community, and that can be actually really bad for health. Not just for people who have less, but also for people who have more. And inequity is really pretty rough on health outcomes. You can look at health outcomes in particular, but you can also look at other types of outcomes that might be impacted by stress and adversity. And then it is important to continue to remember that a trajectory or an estimate or an expectation of what might happen based on conditions that happen in childhood or in a prior situation are not deterministic, right? That's not your destiny. It can be changed. It's just that if you look at the literature on a particular snapshot in time, people in groups who have certain types of experiences are more likely to have negative outcomes than others. It's really important that we all remember that that's not a characteristic of an individual, and it doesn't mean that it's not changeable, but it does mean that to change it, there may be multiple levels necessary, right? So the individual might need to make some changes. The system that they're in might need additional changes and supports, and other types of factors might need to be considered. Okay, so if we're talking about like this or that thing impacts life expectancy, whatever, that doesn't mean that it absolutely will do that regardless of what happens. And in fact, most of us are focusing our attention on how to change that trajectory. What type of intervention or prevention or change would help make a different outcome more likely. So that information about the effects of childhood adversity in particular on lifespan comes from the Adverse Childhood Experiences Study, which was a big study that started in California in 1995 with 17,000 folks. And they were all Kaiser patients. So they looked at their Kaiser medical records and they asked them questions about what might have happened in their childhood. And they connected reports of adverse experiences in childhood to health conditions in the medical record, and then ultimately to lifespan. And that's where that 20-year lifespan reduction number came from. But that particular study was not, they didn't end there. So most states and territories at this time have looked at connections between adverse childhood experiences as reported and health outcomes later, and basically replicated the same type of impact. So the numbers vary a little bit, but the same type of relationship has been found in lots of different contexts. And it's important to remember that the adverse childhood experiences study and questions are a particular set of questions. There are other factors that are likely adverse childhood experiences that are not included. For example, there's nothing on the ACEs instrument about trafficking. And I think we could all agree that being trafficked in childhood would count as an ACE. So you don't need to think about it as sort of set in stone. Lots of people have put in alterations to that set of questions, but the basic idea has been replicated multiple times, which is that serious adversity in childhood without any intervention to change that trajectory does impact health across the lifespan and increase risk for early death. There's lots of interactions between early adversity and later adversity, which an important piece of this puzzle to remember is that we can think about the inflection points or intervention points one of two ways. So you could say, well, if early in life, so that's what this does, this particular slide, early in life plus adversity in adolescence really increases the chance of poor health outcomes at age 32. But the flip of that is an intervention for an adolescent who had a tough early life is likely to be particularly impactful, right? Because the double whammy of two adversities in those two quick development periods or intensive sensitive periods leads to worse outcomes, right? So we sometimes, because we focus so much on early childhood and how important that is, we sometimes get in this mindset that it's hard to change things in adolescence, but it's actually especially important to try because that double risk factor of early life and adolescence increases risk more than just having each individual one or the two of them added together. There's lots of research on how difficult poverty is for child outcomes. And in fact, adversity and poverty are often treated as synonymous, where in fact they're not. So there are lots of examples of families with fewer economic resources who are not living in situations that are more dangerous, are not providing parenting that is less supportive, that kind of thing. But because poverty co-occurs with other types of structural inequities, so can be more likely to have, for example, not as good schools, not as much safety, poor water quality, poor housing quality, that kind of thing. You can see that living in poverty in childhood, those complex risk factors can accumulate. But it's really important to separate that when you're trying to understand what thing needs to be changed, because it matters for what type of intervention or support that you provide. So lots of children in the US living in poverty, up to 41%. And then we see health outcomes in terms of body mass index, blood pressure, fitness, all kinds of things. We see substance use, mental health concerns, lots of things that accumulate, and overall wear and tear on the body. Remembering again that this is not a definitive outcome, just a more likely outcome. And then there's lots of research looking at how poverty impacts the way the brain and body grow in the first place. It's again really important to remember that there's lots of factors here. So what kinds of inputs are coming into the child? It's not just coming from the family, it's the whole context that they're in. So when we see things like this study that shows smaller total gray matter volume for kiddos that have less financial resources at home, something modifiable about that would be, for example, an intervention preschool, right? That would provide those additional resources. Another really important part of this type of work to keep in mind is that we see a lot of action and the impact of income early at the lower end of the income distribution. Now in Hawaii, where the cost of living is high, that $50,000 cutoff might not be as accurate, right? But the basic idea here is that there's a lot of impact of income up until 50,000 in this particular case, which suggests that, to get to a basic set of resources that support brain development that's a certain point, but it's not as if you just get a linear increase with every increase in income, which makes perfect sense, right? And I think we can all relate to that understanding. And this wraps back to the inequality question. It is not sort of better for kids to have, more than $300,000 in income in their family. It's just that a basic set of resources are needed to provide the supports that everyone needs to be successful. So figuring out what that looks like is a complex set of factors, which would include things like sharing resources. So for example, having family that could help take care of an infant would mean that you don't need as much income in order to do that piece, right? So those are that's a place where sociocultural factors would weigh in quite a bit. Okay, and then there's some really great research on scarcity and its impacts. And the important point I wanted to make here is just that the perception of scarcity or the feeling of scarcity, not having enough, impacts the way everybody thinks and everybody reasons. And that's something, if you think about like early in the pandemic, when it was hard to get toilet paper and stuff like that, it impacts people's ability to think and reason about everything. And that's true for everyone. And so sometimes when people make attributions about the types of decisions that people make when they don't have enough resources, the attribution is as if the person makes poor decisions, but really anyone in a situation of scarcity becomes fixated on that particular resource that they need. So thinking about those empty, and I know you guys are having, according to my mom, a lot of trouble getting stuff delivered to the islands right now. So you can probably acutely relate to this situation. There are certain things that really undermine our ability to think sort of more long-term, to do longer term types of investments, to think about, and one of those is having scarcity of things you really need right now, like water or gasoline, basic resources. Okay, and then the inequity piece is really important. This is a complicated slide that you don't need to try to digest, but the main point here is that we have seen in the past, since the 70s, we've seen a dramatic increase in the level of inequity in the country. So the difference between the top and the bottom earners has increased really dramatically since the 70s. And the cost of the difference for health outcomes between the highest and the lowest income groups has grown in that same time period. So not only has inequity gotten larger, the cost of inequity for health has also gotten larger. And this is something that we see across the world. So the relationship between inequality itself and health and social problems in a country can be mapped. Look how linear this is, this relationship. And there's the United States up, in the top corner there. So what's interesting about this work too is that when policy changes change the degree of income inequality, you see a concomitant change in the health and social index, problem index. So if you put in a policy that makes inequality bigger, that would be like a tax policy, for example, then you see more health and social problems. If you put a policy into effect that makes income inequality smaller, then you could see a reduction in health and social problems around the world. So that is a movable target. And again, inequality impacts health for everyone. So that's something that we can all think about, how that impacts us and how we might want to conceptualize those changes. Okay, and then in terms of health outcomes, and this is actually not updated with the current pandemic, which has actually made it worse, but it is important to keep in mind that we sometimes think that things are better in terms of health outcomes in the US than other parts of the world. We're actually 43rd and declining in terms of life expectancy. So, and that is not on par with other countries with whom we have shared sort of sociopolitical realities. So that means that declining means that a baby born now is expected to live less long than a baby born a few years ago. That's not the direction that most people think it is going. And while this is really difficult to hear and tough news to hear, I think it does really make it important that we all think about what are we doing here, right? Like, what are we prioritizing here? And that's not to say that, you know, having a longer life in and of itself is the only important outcome, but it does give some indication that things are not, we're not on par with many of our peers here on this particular thing. And a lot of what's happening there, a lot of what's driving that change are increased rates of death by suicide and death by drug overdose. And I mention that here because those risks, early adversity, so adversity in childhood, is highly connected to death by suicide and death by drug overdose later in life. So these concepts really are all connected and important factors to work on. Okay. All right, and all of that does start really early. So you can see differences in health outcomes in the 0 to 3 period. And you can look for them in different types of ways. So you can see them in dental health. That's something that emerges really early, that you can see dental health is highly related to overall health. So you can start to look for these health gradient differences and try to put interventions in place, you know, pretty early. And in fact, people are most receptive to intervention in the pregnancy and early postnatal period. So that's an important piece to keep in mind when we're thinking about places where we might work with families to provide additional supports. And then just keeping in mind, again, that trajectory is not destiny. There's resilience is really scientifically defined as better than expected outcomes given a particular assessment of risk. And it's really about, so we just talked about ACEs, right? We just talked about the fact that, for example, in this case, if the lifetime prevalence of depression is 2 in 10, which it is on average, if you have 5 or more adverse childhood experiences, that risk goes up to 6 in 10, which is really significant. But if you want to think about what's going right, what's working, and what we want to support and implement, you would want to look then at the 4 people here who had the 5 or more ACEs and did not have the negative outcomes. What did they have naturally? What could be learned from that? It's much more instructive to do that than to compare people with 5 or more ACEs to those with no ACEs, because their experience was really quite different. And lessons taken from one really might not be applicable to others. Okay. We have really big and early developing brains compared to other animals. And this is important because it tells us how much plasticity there is, how much play there is in the system, and how open we are to experience all the things that we can do and how early that starts. So that really starts in the prenatal period, that each individual is taking in information about their environment. That can turn into a risk if the environment is negative, but it also has a lot of potential to turn into a positive or a set of positives, to think about how much plasticity there is in that system as compared to animals that have much more defined developmental trajectories. So we're often talking about early life, how important early life brain development and that kind of thing is. And that's because of the fact that our brains are really underdeveloped at birth, and there's a lot of opportunity to provide positive inputs. And the infant is very susceptible to negative inputs. So this is a study that was done by one of my colleagues here in Denver. And this is about stress exposure during pregnancy. And basically what you see here is that when infants are exposed to more stress hormones in the prenatal environment during pregnancy, particularly early on, they at birth, they show much more responsivity to stress than babies who did not have that stress hormone exposure during pregnancy. So the green line are the babies who did not have high prenatal cortisol exposure during pregnancy, and the orange line is babies who did. All of the babies were given a heel stick blood draw at birth. That's a medically necessary procedure, and it is also a little stressful and painful for the baby. So what you see is all the babies reacted negatively to the heel stick blood draw initially, but the babies who had that low exposure to stress hormones during pregnancy went right back down to baseline and returned to normal pretty quickly, whereas the babies who had that stress exposure during pregnancy continued to stay vigilant and unhappy after the heel stick blood draw. So There may be reasons why both the baby and the mother are more responsive to stress, but basically you can see a difference at birth in how people respond to stressful experiences that is connected to those stressors that they had in the womb. And these kiddos continue to present differently across their life. So at 6 to 8, they were more likely to be anxious and depressed and to have larger right amygdala volumes, which is a part of the brain that helps you respond to threat in the environment. They're still following these kids. They're young adults now. And again, on average, they're mostly doing great, right? But it is a piece of the puzzle, how they experience the world during the prenatal period, and how that has kind of set them up to respond to later stressful experiences. This is another study that shows how impactful the environment is early in life. So this is a study with infants. They wanted to look at infants' brains. They did that while the babies were sleeping. They had them listen to angry or neutral adult voices. And they had asked the parents about how much fighting was going on at home. What they found was that children in families with more fighting going on at home had brains that were more responsive to angry versus neutral voices while they were asleep. So that's telling us that while babies are sleeping, they're tracking their environment for danger, right? They're listening for danger, which in this case is in the form of angry adults. And that's impacting what they're doing while they're asleep, right? So this is a really powerful message about how sensitive children are to the environment and what kinds of inputs they're getting. Again, right away, pretty early in life, and trying to think about how we want to structure our environments so that they can be more supportive. And I just, before this study was published, I really just didn't realize that that sleeping babies were listening to what was happening in their homes. So it's just another way of thinking about how much infants are prepared and trying to think about what kind of world is this and what do I need to do to be prepared to be successful in the world. So we can compensate for the effects of early adversity. There's lots we can do to try to turn back time on this. And the way we think about that is what kinds of supports can we provide? So when chronic or significant stressors happen, what kind of buffering can we provide? And really, we call something a toxic stress when it's both significant and chronic, right? A serious thing, but and buffering relationships are not available. So there's the protection is not there. So it's not as if we're saying that, it's not as if the scientific literature suggests we should prevent all bad things from happening around kids, right, all the time. That's not the take-home message. The take-home message is that kids need support in order to manage the negative things that happen in life so that they can be successful. So we only call something a toxic stress when it's significant and stressful in childhood and buffering relationships are not there to protect kiddos from it. When stressful things happen and buffering relationships are available, then that's generally called a tolerable stressor. So it's not exactly, a great thing, definitely difficult things happen. But if buffering relationships are available, then we don't expect kids to be making significant long-term changes to their brain and body that might, for example, result in long-term health conditions. Okay, and then we know that parents are also changing at the same time, and parents are changing. So we think of this as, I'm going to just go to, I want to show you something, hold on. I don't see it, okay. We know that parents are changing at the same time that their infants are changing. And this makes it a really powerful time for intervention. So parents are also in a sensitive period, and this is true for both new fathers and new mothers, whether or not they're biologically related to the child. They're in a situation where they can be responsive to new inputs because their brains are changing as they adapt to this new role, which makes perfect sense. Your brain is there to support you to do the things that you care about and try to do. But we see these massive changes in the brain when people transition to parenting. They help you, they change the way stress is handled. They promote your positive emotions and bonding. They increase your motivation to care for your infant, and they promote specific caregiving behaviors. All of these changes in the brain are happening when people transition to parenting. And that makes parents both these super powerful agents of change, these buffers against toxic stress, and also people who are undergoing a lot of change themselves. So sum total, the way that makes me think about it is, okay, stress is really difficult and rough, right? Especially if it happens in childhood, it can have these long-term difficult effects, but it can be buffered by relationships. The most powerful people to buffer against relationships are parents, because they're the day-to-day supports for kids. And parents are going through this massive change too at the same time, which can be leveraged, can be used as a positive thing, because they are also really open to experience. So altogether, that has made us develop programming for parents that really attends to what it's possible for them to do. Not just in terms of parenting, but in terms of their own well-being, so that they can be good supports for kids. And then that leads us to, what is it that parents need to be successful, right? Or what is it that caregivers more broadly need to be successful? What kinds of supports do parents, teachers, mental health professionals need in order to be in the right psychological and behavioral space to be supports for kiddos? A lot of that is going to be about helping them work through their own prior history or current history of stress and trauma. So that's a lot of what we do now, is really try to work with adults. Even though I'm really a kid person, my end game is about improving things for kiddos. The way to do that is to better support the adults in their lives, and to recognize that the adults in their lives may be much more likely to have been kids who did not get the types of supports that we're now asking them to provide to their own children, right? So trying to think about this in an intergenerational kind of wraparound way. How do you sort of stop the clock right now in this moment of time you're in, where things are really difficult, and try to dig out from that? It's a set of skills that you need for managing stress and adversity, for processing and thinking through prior traumatic events, and then implementing a different set of behaviors that you want to have now for yourself, for your own well-being, and for your kids. So the narrative I'm telling you, I'm giving you a lot of scientific knowledge, but that's the underlying narrative of the whole story behind it. If we want to change the big picture, long-term outcomes, which is this reduced lifespan, right? All of these negative things that can happen, we have to figure out how to prevent and intervene that trauma and stress early in life. And the best and most powerful way to do that is by supporting the adults in children's lives who are able to provide that support to them. So that's taken me on this circuitous journey where I now work primarily with adults. And we see these massive changes. This is mostly done in moms, but it's the same exact thing you see, pretty much exactly the same in mothers and fathers. So really massive changes that are happening to the brain when people transition to being parents. And they're mostly, they're all growth, and they're positive changes that help you really think about taking care of this particular infant. So I'm not going to go through those changes in detail, but you can actually read lots of this information. I can give you a few different resources to look at to talk about how that particular set of things happen. But it's essentially a bunch of changes that happen to the brain that change the way you orient toward rewarding things like your baby, change the ways that you handle stressful inputs, change how you think about social signals, and about how you respond empathically to somebody else's distress. So those are all different pieces of the puzzle. If you think about trying to parent, it's got those elements in it. And it's really important that we see those changes that support that. It is also the case that trauma, stress, and depression in the adult make it harder for those brain changes to happen, and make it harder for you to use your brain in this supportive way for parenting, because those same parts of the brain are being hit by the stress and trauma that you have experienced as an adult. So again, going back to what I was saying before, this journey that I've taken across my career has brought me back to this really important need to focus on the adults right now who are trying to care for children, or the next layer up, the system of supports in place to support adults who care for children so that they can do this job. And in order to do that, we have to unwind some of this and think about how we all, each of us, handle stress and trauma. And I know there's a lot of conversation about self-care, and there's a lot of in professional development context, there's a effort to do things like have a minute of mindfulness before you start a meeting, that kind of thing. That's all coming from the same place, but just coming at it from maybe a different angle. I bet all of you are experiencing some degree of strain right now. thinking about how hard that makes it to do the things that you're trying to do to support others. So it really is just critically important that we pause and think about how to better handle the stressful experiences in our own lives, the trauma that we've experienced in our own lives, so that all of us can lean in better to support children and families. So I'm going to skip over this stuff. But just remember that the basics of how all of this works is in families. So we want to change, right? We want to change a kiddo. We want to change somebody in that first and most important sensitive period. That's my daughter. And we want to do that by impacting the social and emotional and educational environment, which is largely the young child's family, right? Could be just mom or dad, could be, you know, lots of family members, mom, dad, grandma, cousins, whatever. We need that adult in this. I'm just using myself as an example here. We need that adult to be able to change, right? We need that adult to be able to take that input in. And that adult, as you can see me here in this picture when my daughter was little, that adult might be in rough shape, right? Like, so how are we going to give that adult the tools they need to be successful in that case? So we really do invest in children via programming that also targets parents. There's lots of different really great preventative and intervention parenting programs. You may have different ones or overlapping ones to these. And these are really great resources for making people better parents. But in order to engage with research that makes you a better parent, you sometimes have to first address the things that are limitations for you. So thinking about things like what type of intervention results in lasting behavioral change, what do we know about that? What enhances versus undermines parental agency and efficacy? So you might have the best program ever, but if it makes a parent feel like they're not prepared to do this job, they're not the right person to do this job, it's not going to have the impact that you want. Bandwidth and load, like, is it too complicated? Is it too hard to do? Imagining that, you know, somebody is trying to implement this parenting change, this parenting program, while they're in pretty strained situations. And then, is there any way you can use some type of video coaching methodology? So can the person themselves see themselves in the role? The way I sort of think about this is like, I really love yoga. I'm also really terrible at yoga. If I do it and I'm looking at the instructor and I'm like following along, I think I'm doing a fantastic job. And then I'll catch myself in the mirror and realize that my version of Eagle looks absolutely nothing like the instructor's version of Eagle. And I'm not going to be able to correct my own behavior unless I can see myself. Now, I don't want to watch myself doing yoga in the window at all, in the mirror at all, but I'm not going to get better unless I do that, right? So trying to think about how do we give people a window, an insight into their own behavior so that they can make that change. And then the last piece, which I know I'm harping on a little bit, but are we taking some time for the parent as a person? Are we making sure to address this person and their own personal pressing needs so that they can do this really tough job we're asking of them? So of course, that's where I've focused my attention in recent years, is trying to have programming for parents as people. Seedlings is our parenting program. We also have a few other programs that are for other types of professionals for the same reason. So I'm going to stop here and let people ask questions. I know that was a lot of information, but there's a big picture narrative that I hope got through, despite the pieces of detail. So I don't know what we want to do for moderating questions.
If people want to use the Q&A function, or if they just want to type it in the chat, I can read them out, and we'll try to get through as many as we can.
Great.
While some of those, while folks are preparing their questions, I had one to kind of kick us off. Could you give an example of a social policy that a place might pass that would help with family resiliency?
A social policy that somebody might pass to help with. Was that the question?
Yes.
Interesting question. I'm thinking about at what level that would make sense. I mean, certainly, so one that we're seeing traction on at the federal level is better support for families during the transition to parenting, so paid leave that is more federally protected versus employer dependent, and other types of workplace supports for caregivers. I think the pandemic has also made it a little more clear that flexibility in the workforce demands can be a good thing and not necessarily lead to less productivity. So some types of things can be very well accomplished working remotely, for example. So that would be another type of policy that might benefit family resilience. Let's see, our program works with high-risk families. Great. Yeah, Parents as Teachers is a great program. I really like that program. I agree, Shelley. Let's see. Okay, so that project with age 32 health outcomes, that is a longitudinal study that was done in Minnesota, and they studied the folks every few years, and they continued out from that, but 32 was just the next age point. So at 27 was the one before that. At 27, they did not see health impacts yet of the two, the risk at early childhood and adolescence, but by age 32, they were already seeing health impacts of that double adversity. And age 32 is really early to see things like heart disease or whatever, right? So it was a big deal finding in the earliness in adulthood of the impacts of that adversity. So that's why I use that particular slide. Have you worked with families working? Yeah, so I think I have not worked directly with CPS programming. I think that I know that a number of the families that we have worked with have been in contact at some point with CPS in different ways. We've worked more with support service programs, so like shelters or food banks or WIC or other types of things like that. But we have worked with a lot of families who are kind of actively in contact with CPS. I think that's an interesting way to do it. We have often been asked too about mandating some of the programming that we're doing, or how we would how that would impact uptake. And I'm really not sure, right? You might have a better sense of that, how a mandated participation in this type of program would go. I think there's a lot of one thing that I like about our approach is that it starts with a lot of understanding and empathy for how people get in a pretty difficult situation. So that might be beneficial in terms of engagement for people currently involved with CPS, but I haven't directly done it. Is there a link to that specific study? Oh, the Minnesota study? Yeah, let me see if I can. Well, I probably can't find it for you right this second while I'm trying to answer other questions, but yes, I can look for that and send you that way.
Yeah, we will make sure to send that out when we send out the recording. We have time for one more question if anybody wants to ask Dr. Wattimore anything before we end for today.
I know that was a lot of information. I wasn't able to sort of see how you were responding without being able to see you. When they did a huge part of. I completely agree with you. Intergenerational supports are so critical, and there's really good evidence that that's a positive thing, right? Having it's good for both the elderly, for example, and for the kiddos. I'm totally with you on that, although I of course share that cultural perspective. At my experience of the continental US is that people just don't totally realize that, right? They're so used to being in their nuclear families that they don't really appreciate the benefits, and tend to in fact talk about the interconnections among generations as in a less positive way. So I completely agree with you that is an underappreciated perspective.
Well, I think the rest that's coming in is all praise for your excellent presentation, and we were so excited to be able to have you join us again this morning, even from afar. Hopefully, in the near future, we will be doing things in person again, and we can invite
Yes.
you out to visit your family and continue through with this education. I just want to thank everyone again for joining us. Next week is our last presentation. There's still time to sign up for that. After we close out this morning, we will be sending out the email with the recording, and we'll also include contact information for Dr. Warnemore in case you have any last minute burning questions you hope to get answered. But with that, thank you all so much and enjoy the rest of your day.
Thank you.